Good morning, everyone, and welcome to our seminar this morning. Delighted we have so many participants and an excellent panel to address the concerns that people might have at present. We're shedding a light on women's health, discussing the realities of living with breast cancer during COVID-19. And of course, we're in International Women's Week. It's gone from a day to a week. It might even go to a month. Perhaps it should be International Women's Day for every day of the year. But we think this is a really important topic to discuss this week because, as we know from the World Health Organization, breast cancer became the most diagnosed cancer in the world in 2020 at around 2.3 million new cases. The World Health Organization estimated that 1 in every 8 cancers diagnosed last year was breast cancer. So this needs to be top of the agenda of us as politicians, of policymakers, of the medical professions. And I'm delighted that we have people representing every area of specialism really on our panel today. We look at the patient's perspective and the medical experts' view of the issue at present. Look, breast cancer needs to be the focus all the time without anything to do with COVID-19. But of course, with COVID-19, there are extra questions and extra issues that come to the fore. I've just done a report in the European Parliament on the differential effect of COVID-19. And of course, it has a differential effect on women. And what we want to explore today is the impact that it's having on those women who have been diagnosed with breast cancer, who perhaps need a diagnosis, who are in the middle of treatment. And we want to raise the very obvious questions that would be on the top of one's mind if you were in that situation. So I hope this can be a very useful seminar for the women that we are honored and men who are joining us today. We're delighted with some of the initiatives recently. Of course, the EU Beating Cancer Plan. We're really pleased to see the greater focus on cancer right across the European institutions, the European Parliament. We have to make sure that translates into early prevention services, early detection, support to women who have breast cancer, and greater resources to the medical profession and all of the other professionals who work to get the best possible outcomes. So we've struggled during the past week to get access to good quality procedures. People have been concerned. Access has been denied in many countries to really essential healthcare programs and screening and so on. We're worried about this. And we're wondering, what should women do now? So these are amongst the topics that we will discuss today. We want to bring more attention to breast cancer patients and survivors' daily realities at present, to raise awareness for prevention and diagnosis, and enabling women to take ownership of their own health and their cancer journey. The pandemic has a devastating impact, but we don't want to see even greater impacts if we don't do the right thing for other diseases and other issues at present. So we're going to have a look at that. We want to make sure always that the voice of the survivors of cancer patients is heard, and we want to avoid interruption of procedures. Cancer does not wait, as we know, and we are a year into this pandemic. So I'm going to start by inviting Barbara Klein. Barbara is the Communications Officer at Europa Donna, and it's the European Breast Cancer Coalition. She's a lot of experience, both personal and also professional, working on this issue. Europa Donna is a wonderful organization. I came across it many years ago myself in Ireland. It's across all of the member states and is a great place for advice, professional advice, combines professional advice, scientific research, and really speaks about the very best that we can do for those who are experiencing breast cancer. So Barbara, over to you. Look forward to hearing what you have to say. Thank you.
Thank you, MEP Fitzgerald, for that wonderful introduction and also for highlighting the issues that we're going to talk about today. So as MEP Fitzgerald said to you, I am a communications officer at Europadona, the European Breast Cancer Coalition, and I am also a breast cancer survivor myself. I was diagnosed in the end of 2016, and in 2017 underwent a bilateral mastectomy, chemotherapy, and then started endocrine therapy, which I am still currently taking. As part of my follow-up from my treatment and because of my family history, I had made the decision in January of 2020 to have a bilateral oophorectomy. This was, of course, before anybody even knew about COVID or what we were up against and what we were going to be facing in the year to come. So as many elective surgeries were blocked, of course, when Italy was hit. Italy was the first country that actually went into a lockdown. 1 year ago today, actually, was the day that we were completely shut in our homes. And so everything was postponed. And of course, this provoked a little bit of anxiety because I had finally made a decision to do something and then I didn't know when it was going to happen. So when things started to open up a little bit in May, I received on a Thursday afternoon a call from my institute saying, we have an opening on Monday for surgery. Can you come in tomorrow for your pre-op and to do a COVID test? Needless to say, I was a little stunned. I really didn't know what to say because I wasn't expecting it at that time. And I said to them, I said, can I have, a little bit of time to discuss it with my husband? Because, there's also the kids to organize because they were at home homeschooling. They said, okay, you have 10 minutes to decide. So I hung up the phone and I was like, oh my gosh, what am I going to do? Because of course, my first thought was, what about COVID? Is it going to be safe to go into the hospital? And that was my first fear. I was actually more afraid of that than I was of the actual surgery. But then, when I thought about it, I knew that the institute where I was going to be operated on was a COVID-free hospital. So they weren't treating COVID patients. I was going to be COVID tested, which of course, as a little side note, I had actually was supposed to get my hair done after having been locked in since March that weekend. And I had to cancel it because I couldn't go anywhere because I had to quarantine after doing the test. But the other downside was that on Monday morning, my husband drove me to the hospital. He dropped me off and he came back to pick me up on Tuesday afternoon. So I had to face the waiting for the surgery, the overnight and everything on my own, which is what a lot of breast cancer patients that are being diagnosed that have to undergo surgery or even treatment during the COVID time is that they have to face it on their own. They can't have their partner, they can't have a family member there to support them. I was lucky that everything went well, except there was one slight hiccup that they were supposed to call my husband and tell him that everything was okay. And when I finally woke up, I realized that I had a ton of messages that my family had no idea what had happened. And then I realized that the hospital had called my cell phone instead of his to inform him. So, this goes to show that the medical staff, they're trying their best. They're trying to inform the family members that can't be there, but sometimes there are, hiccups, which is anxiety provoking for the family members that aren't allowed access and are waiting at home for information to find out if, everything is okay. But I made it through and, I managed to arrange everything with the family. And the screening was stopped in Italy and checkups were put on hold. Many of our countries as well. Folks said that screening in the first round was completely stopped. So then they're starting back up, but there's the main issue of women are afraid to go to screening. So even though screening has started up now, they kind of thought, well, maybe I'll put it off till spring because then I can, things might be a little bit better in the spring, so it won't be so bad. So our groups are working very hard to try to inform women that it is safe to go to screening and that they shouldn't put it off and that they need to do their follow-ups and you need to continue on and that the hospitals are safe. They're taking steps. There's COVID-free pathways now. And so we need to assure women that they need to continue on. Also, because as a survivor, you know, there are other things that in your life that are important, like exercise is very important to combat the side effects of the hormonal treatment that we're on, and gyms are closed. In the beginning, we were closed in our homes. We couldn't even go 200 meters outside of our house. So, and you're working from home, you're taking care of your kids, you're taking care of the family, you're cooking. And so you're taking care of yourself takes kind of a back seat. And I think that that's something that we need to be aware of. And luckily, many of our groups are on the local level. They are dealing more on a day-to-day basis with patients, and they are talking to them, and they're giving them advice, and they're trying to help them through the loneliness and anxiety that patients are facing in this moment. So I know I've overgone my time, so I'm going to pass it back to MEP Fitzgerald, but I know more will come out in the discussion afterwards. So thank you again for letting me take part in this event today.
Thanks, Barbara, for that very personal story. And we do know from all of the evidence and the research that women are actually carrying a lot of care duties, as well as maybe work, their own professional work as well, that the sharing in the home isn't what it should be yet, that women still carry more. And as you say, personal care and thinking about oneself, it's really important to continue to do that during this period. But it's a very demanding, psychologically and practically, very demanding time for women with a lot of extra demands. I'm delighted that our next speaker is Dr. Isabel Rubio. She's a very experienced practitioner. She's the head of the breast surgical oncology at the Clinical University of Navarra in Spain. She's the USOMA president and ESSO president-elect. So thank you for all of the work you're doing, Isabel, and we really look forward to your views. Thank you for being part of this Transforming Breast Cancer initiative and giving us your time today. Really look forward to what your views are on breast cancer and COVID and the interplay, what you're seeing at present. Thank you.
So good morning, everybody. Thank you, MEP Fitzgerald, for this great event and for guiding and leading this Transforming Breast Cancer Together initiative that I think it has placed breast cancer in the front line at the European Commission. So let's start with two things important here. And one is what happened in the lockdown and what happened at the beginning of this pandemic, that we've seen already many studies showing that in a couple of weeks, probably by beginning of March or end of February, we start having all these patients with COVID, and then the hospital from one day to the other start having problems with ventilators. And I think that's the first problem that we had in the surgical field. So at some point, all the surgical specialties were advised to just undertake emergency surgeries or procedures that cannot wait. But all the elective surgery needs to be postponed because there were no anesthesiologists. They had to go to the ICU. We didn't have ventilators because they need to be used for the COVID patients. So what happened to the breast cancer patients? Well, we had patients who came to the clinic because they felt a lump, and they were diagnosed at the same time in the radiology department. But then when we start to plan the treatment, one part of the plan was not available, and that was the surgery. So this was a really upsetting moment for patients because, as we know, when a woman feels a lump, even though after knowing all the information, the first thing the patient wants is to take out the lump. Of course, we know that in breast cancer, and after discussing with the patient, sometimes surgery is not the best option. But in many of these cases, they couldn't have surgery. And let me tell you that I think that at that moment, it was very important to have the patient in front of you, because the telemedicine can work sometimes in some specialties. But I can tell you that in our specialty, it's very difficult to talk to a patient by the phone and tell her that she cannot have surgery, that we are going to try other type of treatments before, that they will work because they always work. But it's not really the initial plan that we would like to have. So that was really upsetting for the woman. And then we have this other group of women who felt alarmed and were so afraid of coming to the hospital that they just stay at home and wait until the lockdown was finished and then came back like 3 or 4 months later. And we know that in some types of breast cancer, if you delayed the diagnosis for months, for more than 4-6 months, sometimes you get the tumor spread to the lymph nodes. So we have these two types of tumors, and it was really difficult to deal with all this situation. We had also another type of patient, and it's the one that when we had an operating room for doing the surgery for breast cancer, then on the preoperative, the patient got a chest X-ray and she was infected by COVID. So then she has to go home, do the all the period of staying at home with the breast cancer and couldn't have the surgery. So, you know, we have dealt with several different types of patients, different stages of disease. And I should say that now, 1 year after, patient can come to the hospital with no problems at all, because the hospitals are safe and we can do all the diagnosis and all the procedures. Even we need to know how to live with COVID, and I think we are learning now. We need to take care of ourselves, take care of, if we feel alarmed, go to the hospital, and we can live with COVID because we know how to live with COVID now. And I think that's my message to the woman now. Thank you very much.
Isabel, thank you so much. I want to ask you about the impact of all of that in our Q&A later. And I also want to ask you about the impact 1 year on of delayed diagnosis, and how much worry is that for women, of cause for concern, and what should they be doing now to catch up, if you like, and are you worried about that 1 year? Our next speaker is Dr. Fatima Cardozo, who again, like Isabel and Barbara, does a huge amount of work in relation to breast cancer. She's the director of a breast unit, Champalimaud Clinical Center, and she's president of the ABC Global Alliance. So working hard, both clinically and, if I say politically, it's with a small p. So Fatima, over to you now to hear your views on the impact of COVID on breast cancer and the key messages for women. Thank you.
Thank you very much, MEP Fitzgerald, for leading this event that it's so important. As you say, 1 year on, and we are still fighting to learn how to live with the COVID, as Isabel mentioned. I would like to say first that I agree with everything that Barbara and Isabel pointed out, but I will add a few additional points that advanced cancer patients or metastatic cancer patients face. And of course, our work is more dedicated to advanced breast cancer patients, but what I'm going to say touches all types of cancer. So when we are living with a situation of advanced cancer, it's most of the time an incurable disease. So the whole trajectory is already very difficult. And it is extremely difficult, even more, to do it alone. And as Barbara pointed out, there are many parts of the trajectory of the cancer patient where now they have to be alone. They have to go alone to the treatments, stay on the day hospitals alone, go to the appointments alone, and sometimes even be in palliative care alone. And this has extremely negative impact on both the patients and the health and the healthcare professionals. It's very hard on us as well to see patients suffering alone, but also on their families and caregivers. So it has had a huge impact. And of course, we try, and perhaps what I would like to say, for not just for all the women and patients that are listening, but also to the health providers that are listening, we need to be flexible in certain situations. So it is very important to let someone go in with the patient in the appointment, if it is a first appointment, if you're going to explain a diagnosis, if you are going to take a decision for the treatment, but also if you're going to announce bad news that the disease is getting worse and that you need to take another decision. So it's also very important to either allow for someone to get in with the patient or use one of these technologies to have a video call with the family, and particularly calling the attention to palliative care and sometimes terminal care, that we understand all the risks, but I'm sure that everybody also understands that dying alone is something nobody deserves. And so we have to find a way of compromising to allow that people are taken care of correctly during life, but also are allowed to be with their loved ones when time comes to end this life. So that's one of the things I wanted to call also the attention. It's a hard thing to talk about, but I think everybody would understand why I'm calling the attention to this particular problem. Thank you for the invitation.
Thank you very much, Fatima. Look, that's really critical point you're making about, I think we need more best practice guidelines during COVID for the treatment of people with patients with cancer, the issues that the panel have been raising about who is with the person on a first visit, for example. Many places at the beginning were so concerned about COVID, understandably, that nobody could accompany or see anybody at any time, even up to the point of death. That's still the situation in many places. But let me start with a very practical question that's come in here on the Q&A. Let me just get it here. It's from Biba Deva. First of all, she asks, how was the problem with postponed surgeries overcome? Is there some system provided from the hospital for continuation? And is there some pathways destined to continue with the diagnostic procedures and surgery? So that's a very practical question about, to both of our doctors, how you dealt with all of those cancelled surgeries, and have you caught up now, and what's happening? And then there's another very interesting question. I have to see where it's gone here from somebody else. I'm just missing the name at the moment, but I know what the question is. I'll find the name in a moment. It's a very practical question. Let's start with it. Should you get a vaccination? This participant says, my friend is starting treatment on Monday for metastasis, and she's saying metastatic breast cancer, and she's saying, when should I have the vaccination? Should I go ahead and have the vaccination? And it's a general question, I guess. Should people try and get the vaccination before treatment? Can you have the vaccination during treatment? Are there any side effects you'd want to alert women with breast cancer to? So I think let's start with that one. Who'd like to come in on that?
Perhaps I'll start, because most people are afraid when they're doing chemotherapy if they can be vaccinated or not. So let's say that the most important message is you should be vaccinated. In principle, every cancer patient should be vaccinated. There are, of course, exceptions based on other diseases that you should discuss with your oncologist. That is for sure. And it's something that you should discuss very dedicated with your oncologist. But in principle, everybody should be vaccinated. It's also perhaps later, MEP Fitzgerald, we can discuss why in certain countries, cancer patients are in the first priority, and in other countries, they are not. And so that leads also to inequalities around Europe on accessibility to vaccination. But coming back to the question, there are, as far as we know, and there are many unknowns in this field, but there are better moments to be vaccinated according to the treatment that you are receiving. So for example, if you are receiving chemotherapy that decreases your immune system, the best moment to be vaccinated is just before the next cycle, when your immune system has already recovered. And this is not because we are very much afraid of the side effects being worse, but it's to improve the effectiveness of the vaccination. The same applies if you are doing other treatments that decrease that are what we call immunosuppressive, that decrease your immune system. There are many, like the CDK4/6 inhibitors or others that we use in breast cancer. For other types of treatment, there is in principle no major problem. So for example, like Barbara said, if you are doing endocrine therapy, it really doesn't matter. It doesn't decrease your immune system, so you can be vaccinated at any time. If you are also doing something that is common like anti-HER2 therapy, just anti-HER2 therapy, it's also possible to get vaccinated. We usually try to do it just before you get another shot, just to, again, to decrease the interaction. And lastly, which is a question that everybody asks, what if I'm doing immunotherapy? What is the interaction? So that is a bigger question mark. Nobody knows, but in principle, immunotherapy stimulates your immune system. So there should not be, again, a major issue with the effectiveness of the vaccine. So again, we try to give it just before you get the new treatment. So when your body is better to receive the vaccination. But bottom line is, in principle, and wherever when you are called and when you can have access, you should be vaccinated. Choose the best time with your individual oncologist.
So Fatima, that's all very well if somebody is actually seeing their doctor. Do you think that many women are actually maybe delaying appointments? Because I think what you've just said is such fantastic information for people to have, that we need to get that out there, because I wonder if breast cancer patients are at home wondering about that, or do you think, and also it all means that there needs to be really good coordination with the public health doctors and the public health programs. And I wanted to ask you, and then I'll go to Isabel, I wanted to ask you, would you put, if you like, vulnerable cancer patients ahead of age in the cohorts to be vaccinated? Because right now it's about third in some countries, it's 2 in others. I guess as a specialist in this area, what would you say? You'd probably say higher up, would you?
I would say that there are many types of cancer patients, and cancer, as we all know here in this call, it affects 1 out of 3 Europeans. Soon it will be 1 out of 2. So of course, not everybody that has been touched by cancer can be first priority. We wouldn't have vaccines for that. But there is a group of patients that is under active treatment. So meaning those who have just been diagnosed and have to do some treatments, or those who have metastatic disease that are very fragile. And those should be in the first priority. The ones that are, like Barbara, already doing just endocrine therapy, their risks should be assessed by other diseases they may have, because that part of the cancer pathway is not interfering majorly in the risk. So I don't think we can take all cancer patients in just one group. We have to divide them.
Okay. And Isabel, perhaps I'll take up that point with you. Is there enough coordination between the experts in cancer care and the public health vaccination programs for COVID? Is that a problem, or what is your experience? What about any side effects of the vaccination that cancer patients should know about?
Yes, well, I completely agree with Fatima, and I think she explained pretty well that any cancer patient that is under treatment, can be vaccinated and it will be good. The only problem that we have is that we don't have enough vaccines. So I think if you start with that and you have to, and when all the countries decided on the groups they were going to vaccinate, I can tell you that many of my patients didn't even realize that they had breast cancer and they need to be vaccinated, because they have in their mind the age group. So it's like, okay, it's not my age group, so I will just wait. But I agree with Fatima, we need to take into account those patients just diagnosed and under treatment, and those ones who are really survivors that are with no treatment or with hormone treatment. And yeah, let me tell you that we've seen lately since the vaccination started, that when you have the vaccine in the same side of the body, the lymph nodes that are under the arm are enlarged, became enlarged, and that's on a reaction to the vaccine. Well, we have found out that we have some breast cancer patients who feel a lump, go to the hospital, are diagnosed, and they have breast cancer. And when the radiologists do an axillary ultrasound to check the axillary lymph nodes, so the lymph nodes under the arm, to make sure that they are not infiltrated by cancer, guess what? They are so enlarged that in some cases they biopsy them, feeling that they may be related to the cancer. So if you have had the vaccine and you feel a lump and you go to the hospital and you are diagnosed with a breast cancer, tell the radiologist, tell your specialist that you have had the vaccine, because we know that those axillary lymph nodes, the lymph nodes under the arm, may be enlarged just because of the vaccine. So, you know, all women need to, all the radiologists and the specialists will know about that. So we can avoid sometimes unnecessary biopsies or unnecessary surprises that the patient is so scared that she has the lymph nodes metastatic, and it's only because of the vaccine. Yeah.
Isabel, that's such important information. I really feel we have to get that out there and do maybe Q&A leaflets or on the topics we're discussing here this morning. I'll come to Barbara in a moment on that. But before I do, Isabel, I asked a question that had come in. I think it was, yes, it was from Biba Dodeva. And that was about how have you been able to catch up on the cancelled surgeries and what are the pathways?
Well, you know, it was not difficult to catch up on the surgeries because on some patients we start other systemic treatments and then, you know, we follow by surgery. Our operating rooms are fully operating right now, so we don't have problems with restrictions. But of course we need resources because, you know, at some point we will have to increase the operating rooms to put up all the cancer patients, because it's not only breast, it's almost all the cancer patients. But I'm more worried now, and I think that we need to have more resources is on the screening, because the problem is that the screening has had stopped for almost 6 months, and then you restart the screening, but then you have all this backlog of screening people, thousands of women, and we need to detect the cancer at the early stage. So we need to put resources on having the screening on those patients who didn't have it, and have it at the same time as the ones that is now the time to have it, can have it all together. So I think screening is a huge problem that needs to have resources and be resolved.
Thank you so much, Isabel. I just yesterday, I was talking to a friend who needed to be screened for a different disease, actually. And she said, oh, no, I won't do any screening. She had some symptoms. And I really believe this is a major issue, that people are nervous. Some more questions coming in, but let me go to Barbara first for a comment on the discussion so far. Barbara.
Yes, thank you, MEP Fitzgerald. I'd like to say over the last year, because we've had to turn to a virtual world, we've been holding roundtables with our groups on a regular basis. And we also did a brochure on COVID and what's happening in the various countries. And most of our countries, screening was delayed in the first lockdown. In the second wave in the fall, not so many were shut down, but of course they were still trying to catch up. And they were finding that women were afraid to go back to screening. They were going to say, I'm going to wait till the spring because the vaccine is going to be ready. It'll be safer to go in the spring. So our national groups have been working really hard on information campaigns within their countries to try and let women know that it is safe to go back to screening, and that they should, that if they feel, you know, a lump, they should go back to screening and not let it slide. I know there was a study that came out in Italy in just one region. They were looking at the diagnoses, the difference between March of last year to the year before, and there were less diagnoses, but they were getting more women that were coming in metastatic, because as Fatima said earlier, you know, if some of the cancers are fast growing, and if they're not treated, you know, 2 months can can make a huge difference in your chance for survival. Sorry.
Well, Barbara, this is a very, very serious issue. I mean, Fatima, we're 1 year into the pandemic now, 1 full year. I think every screening was cancelled effectively in the first few months. What about the catch up? And are you worried about the impact of that 1 year? We don't want to scare people, but we really do want to say, get out there and if you have symptoms now, go out and do the screening. I assume that's the message, but I do want to link that with a question that's come in from Iona Carolam Populu. Thanks for this hands-on webinar. Could you please explain how can we ensure 100% COVID-free pathways in the hospitals? You see, that's the question people ask. Okay, you're telling us to go to the hospitals, but are you sure, Fatima, you should be saying that? That's the question.
Thank you. So I'll come back to that in just 1 second. I just wanted to put a number on this issue about the screening and the let's say misdiagnosis. It's estimated that we have been diagnosing 40% less, so 40% less cancers. And what we see in our practice is really a decrease in the number of new patients. And of course, there is no decrease in the incidence of cancer. The cancer continues to rise. So these are many people who have symptoms and have not looked for medical attention and for a diagnosis. And there are also those who don't have symptoms, but we didn't pick up early enough because they didn't go for screening. So what this will lead is that those who are not picked up in the screening process will develop symptoms. And at least we need to send now this message, please, the cancer mortality is much higher than the COVID mortality. And I know we are all very scared, and it's hard not to be because you open your TV and all you hear is COVID, 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 and everybody is scared. But please remember that cancer kills more than COVID. And it's true that cancer doesn't spread like COVID spreads, but cancer is still much more frequent than COVID is. And so if you have a symptom, do not wait. It can be the difference between having a curable cancer or an incurable cancer. And
yeah, Fatima, let's go back to what you just said there, because, you know, we're all so frightened by COVID, the spread, the contact, everybody's been really cautious. I think what you've just said is critical, that, you know, I want you to say it again about cancer and COVID, because I'm not sure people believe it.
Well, the truth is that the COVID mortality rate is fortunately not very high.
Okay.
This we know, right? The problem with COVID is that it spreads very quickly and that you can get infected easily, and sometimes you don't even understand how you got infected. But it does not kill the majority of people.
Okay.
And cancer, if not diagnosed early enough and if not treated early enough, has a very high mortality rate.
That's a really critical question that you've answered there, Fatima, and I'll come to Isabel in a moment. But we have quite a lot coming in on the Q&A, and I just want to give you a flavor of it.
Do you want me to tackle this 100% COVID-free?
Yes, that's important, and I get Isabel to answer that as well. Okay.
I don't think there is.
Weigh up the risks about going to a hospital versus screening or going to see your doctor.
So there's no place 100% COVID-free, right? Because we don't even understand sometimes the pathway to infection. But one important message is that cancer centers do not see COVID patients. So we are considered COVID-free in that sense, that we do not treat COVID-infected patients. Of course, those department of oncology that exist in a general hospital is different, because in a general hospital, you have all types of patients. But usually they do separate entrances. They do a triage of patients at the entrance. And what we also do in both the cancer centers and general hospitals is a triage like calling, if you're coming to the hospital, do you have any symptoms? And
Yes.
if you have any symptoms, you have to be tested before you go to the hospital.
Okay.
And
Fatima,
then,
yes, sorry to interrupt you. We have only a few minutes left. I want to give you all a flavor of what's coming in. It's been incredibly useful, I'm sure, for all the participants as well. Let me just say, Khadija Banwo, Dr. Fatima, please, is it possible to have the vaccine injected on the lap instead of upper arm? I'm speaking from the angle of a breast cancer patient. Hold on to that one, Isabel and Fatima. Then there's another question, Violet, in Kosovo. She's very concerned because the vaccinations haven't started there yet. She runs a breast cancer organization. And then another question, was there an increase in mastectomies in order to avoid radiotherapy due to COVID restrictions? Has there been any, from Kristen Pilati, has there been any positive impacts from COVID? Here in Australia, we have seen an increase in hypofraction radiotherapy, is it? An increased multidisciplinary meetings for metastatic patients. I had breast cancer some years ago. I'm over 74. I'm still waiting for my vaccine. Should I be worried? Then we have Cheryl Cruways, who also runs an organization. She'd like to link with you afterwards. And she has a detailed question, which I don't think I have time to go into now. It's about dense breasts, supplemental screening, and that a clear normal does not necessarily mean that cancer is not present, and that screening guidelines vary, etc. So she's quite a detailed question there. So look, I want to thank everybody who's been involved, all of the participants. I think some initiatives may come out of our event today. This event, just to let you know, I should have said it at the beginning, is being recorded. So there will be access to the details in it. But no doubt Barbara and Fatima and Isabel will also, be spreading the word about what has come up this morning. So I'm going to go to each of our panelists to try, and I know you can't answer those questions in detail in a minute or two, but give us your best shot at it and on the questions that have been asked there. I'll start with you, Isabella.
Okay, just quickly to answer the questions. No increase in mastectomies because really you can have radiation therapy, and the radiation therapy departments has been ongoing. So, we have not increased mastectomies, and we can do oncoplastic not to do that. Second thing that I want to mention is we know now how to live with COVID. So please, hospitals, as Fatima said, are safe places to go. Fill a lamp, get your mammogram if you need it. If the screening is stopped, go and get your mammogram and say that you need your mammogram. So just push for it. And the other question about whether, if I think there are not many studies, but if you have an axillary lymph node dissection or you have a lymphedema, don't use that arm for the vaccination, because you will have probably an increase in the lymphedema because your lymph nodes are not working well. But I think you can have it in another part of the body, and don't use the arm if you have had an axillary lymph node dissection. In other cases, even if you are diagnosed with breast cancer, you can use that arm and there is no problem.
Okay.
Thank you. I think I will let my other colleagues.
Thank you, Isabel. So quick word from Fatima and a final word from Barbara. Fatima.
I will choose to tackle that. We did learn some good things out of COVID. I think it's important to end with a positive note. I think that, yes, so what Kirsten is referring to, people were not using shorter duration of radiation treatments because of financial issues. And now COVID has forced them to go and do the right thing, which is shorter radiation courses. And we also learn how to communicate better, I think, use these new technologies to communicate with patients. We have learned also something we didn't tackle, but how to do clinical research, so clinical trials in a better way, in a faster way. So the only point that I will end is probably for health care providers, is that there are good things about telemedicine, but that there are bad things as well. We are one way 1 year over, we cannot continue to see patients at a distance. So we need to see them face to face. We need to examine them. And
Yes.
I plead that everybody goes back to seeing patients physically.
Okay, Fatima, somebody just asking again, just need a confirmation that breast cancer patients should have the vaccine on the thigh as opposed to the arm. Is the answer to that yes? No?
No need. What Isabel was saying is that if your cancer was on one side and you had surgery to the axilla, use the other arm.
Okay, all right. And then again, people saying, should cancer patients have the vaccination? I think the answer is yes. Am I right? And Barbara, I'm going to come, and by the way, there is a point made in the Q&A, which I think is very interesting. It's about patients with lymphedema who might be going to see a physiotherapy, that also has got very interrupted. And I think that is something that's an important point for us to acknowledge as well. Barbara, final word from you as we finish the Zoom call.
No, I just would like to thank everybody for their input, and also just to get the message out there to especially the patients that are out there, as we've said before, that you shouldn't be afraid to continue with your follow-ups. To go to screening, if you feel something that's not right, you should go to your doctor. As Fatima said, we have learned some good things from COVID, but yes, I agree, especially as a patient, technology is great, but that face-to-face meeting with your doctor can't be avoided. I mean, you need to have that. I mean, there's certain things that you can do via, televisit. For example, I had a call with my geneticist the other day, and that was on Skype, which is fine because he doesn't need to actually visit me. But when you go to see your oncologist, it's important to be able to go. And I think women should know that they should feel safe enough to be able to go. And that we also need to, the patient advocates need to get the word out there, especially for the screening, because that is the really important issue that, as Fatima said, 40% less, cancer patients diagnosis, that's a lot. And that really is going to have an impact in the future. So we really need to keep pushing and get that moving again.
Thanks very much.
Go back to exercise. Go back to exercise.
Yes.
Okay, good message. Isabel, Fatima, Barbara, thank you so much for your expertise, for choosing to challenge breast cancer in all its forms and all of the issues that have arisen during COVID. This has been a superb, I think, piece on information for breast cancer survivors, or for those who are worried they might have breast cancer. You've looked at the interaction with COVID-19 and the very basic questions that I think are out there about COVID still for those who have breast cancer, and indeed for many people with other diseases as well. We've all been very overwhelmed by the pandemic, and medical services have. But as you say, Fatima, Isabel, and Barbara, we've got to get back to focusing on what needs to happen in relation to breast cancer in this recovery, but ongoing period in relation to the pandemic. So thanks ever so much, not just for today, but for all of the work that you do all of the time. And I'd also like to thank all of our backup staff who've made this webinar possible, who support us in the Transforming Breast Cancer Initiative, and to all of our own staff. Una works with me on this, and all of your staff who help you and give you the opportunity to do this public awareness type of webinar, because it's really important and hopefully will make a difference to many individuals and their families who are courageously battling cancer and other diseases. Thanks so much, and we'll finish the webinar now. And thanks to all of our participants. There's been a very lively chat there, and I think very good and practical questions that we've answered. Thank you all, and have a good day and stay safe.
Thank you.
Bye.
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 Bye.